We're very pleased to have to speak to us today, and he's going to be talking about imaging, predictive CT imaging. That's Carlo De Cecco. And Carlo started out his medical career, actually his undergraduate career in Rome, where he grew up, and he went from Rome, University of Rome, and then he went to Spain, and then came back to the Medical University of South Carolina. And from there, he did 4 different fellowships, got a number of titles to add to his name. And when we started asking about things for Grand Rounds this year, one thing that the house staff kept saying is we want to hear something about imaging and how to use imaging appropriately. And then when I went to radiology and asked who should do this, they pointed to Carlo. So we're expecting great things out of it. But we're very pleased to have it, and I won't try to go through all the various degrees he has and all the various awards, but I'll tell you they're innumerable. And again, we're delighted to have you.
Thank you very much. Thank you again for the invitation. It's really a great pleasure to be here with you. And also I want to specify that I didn't do for fellowship for pleasure, but because I needed for the board certification. But they were very useful, of course. And so today we're going to talk about the state of the art in cardiac CT, because there are a lot of things that have changed in the last 10 years. I want to share with you this little, inside joke that I started doing cardiac CT in 2006. And at that time, technology wasn't that great, and so we need to heavily beta block the heart. And we were joking that to get a good cardiac CT, you needed a cardiac arrest. So right now, things are pretty much changed. You will see that the image quality definitely is something that is on our side. Those are my disclosures. And again, as I was saying, the image quality has greatly changed over time. Right now, we can acquire very good and detailed picture of the coronaries, showing and very well matching the coronary angiography, with the advantage that we can see, as I'm going to show you, the wall. So we can really see the atherosclerotic plaques. We can really see the plaque burden all across the coronaries. And we can also see what is out of the lumen, what is surrounding the lumen, the wall, and outside the coronaries. Just to start with some cases, I want to show you the first case is a 56-year-old male with chest pain after a diving session. There is a residual burning chest pain. Past medical history is a positive medical history for several factors, and also the family history is going to be positive. In this case, the patients underwent to a cardiac CT. And what we saw was pretty nice, because the right coronary arteries was pretty good. You don't see any wall abnormalities. There is no evidence of atherosclerotic disease along the RCA. The circumflex is the same. It's a good, nice circumflex without any wall or abnormalities. However, when we go through the LAD and left main, you see that there is at least a moderate to severe plaque in the proximal LAD, causing more than 50% stenosis. The plaque is a combined plaque, a composite plaque with calcium at the shoulder, and then a hypodense core. And when we're going to look closely at the plaque, doing maybe some cross-sectional imaging, you can see very well this plaque. This is a plaque with a very dense core surrounded by hyperdense material. This is called the napkin ring sign. This is an high-risk plaque. So we know that this is going to be an high-risk plaque, a vulnerable plaque, that there is an increased risk of this plaque for ulceration and thus causing a mastectomy or a myocardial infarct. The napping ring sign is one of the sign of the feature that we have to characterize a plaque, so to do a plaque characterization based on the risk profile of that plaque. And again, it's thought to represent the necrotic core, the hypodense region, surrounded by a fibrous cap and peripheral calcification, and is again a sign of plaque instability and a greater risk of rupture. What is even more interesting in these patients that we could do a comparison with a prior study that the same patients did in 2015, and when we do the comparison, you can see how in just 2 years the plaque has changed. So we had a growth in the plaque, especially when we compare the same cross-sectional image. You can see how significant was the plaque growth, and those also the development of these, let's say, high-risk features. So in these patients, we can see that there is then a suspicious, let's say, high-risk plaque, and also which has significantly progressed in few years' time. In the second case, a 15-year-old female with acute chest pain. In this case, the pain was very acute. The EKG, there was no evidence of ischemia. The troponin, there was some alteration. They decided to send the patients to us for a CCTA, and actually the finding was pretty interesting because we found a pretty acute abnormalities. You can see that there is all this akinesia of the anterior wall and apex, and also you can see that there is a very nice matching with LAD. The LAD is non-opacified. There was an acute occlusion of the LAD, and in this case causing a nice, also matching very nicely the hyperperfusion defect in the LAD territory in the anteroseptal wall, as you can see with this reconstruction that we performed to look at the myocardium. The patient was promptly treated. They went through a revascularization, and there was a complete restitution ad integrum of the myocardium. So a very acute case where we, with the coronary CT, we were able to identify the abnormality in a hyperacute state. Our third case, before we move to the topic, a 64-year-old female with an acute onset of chest pain, palpitation, nausea and aphoresis, and in this case the past medical history is insignificant, troponin are mildly elevated, and there is an ST segment elevation in V2 and V6. In this case, of course, the concern, they send us the patients, but what we saw is that there is no evidence at all of coronary artery disease. So in this case, we don't see any plaque, we don't see any significant stenosis. So again, another patient with a confounding presentation where we can see that the risk factor of the coronary is not the reason for the chest pain, and also this patient has a very low risk for future cardiac events because in the coronaries there are no atherosclerotic plaques at all. So based on this, just to give you some background where we are coming from in cardiac CT. We are coming from all the studies done in the first, in the 2000, in the decade, that were efficacy trials trying to establish the real value of CCTA compared with the catheter angiography. And we know from the studies, from the accuracy trial in 2008, for example, one important thing that CCTA has an extremely high negative predictive value and sensitivity. So we are very good in detecting the coronary plaques, and we are very good in ruling out the atherosclerotic disease. So telling that in that case, the plaque is not going to be, let's say, a significant stenosis. These values, also the specificity is pretty good. The predictive positive values is good but less accurate due to the spatial resolution, which is lower compared with the coronary angiography. In this case, these results have been confirmed by several multicenter trials, the CORE 64 trial, again showing a 99-100% negative predictive value, and also the multi-vendor, multi-center 64 CT trial showing this result with the first generation, of course, of 64 CT. So we are talking about 2008, 2005. However, and based on that, we know from several multi-center studies and meta-analysis that actually for the detection of coronary artery disease, we are the most accurate technique. So we have a sensitivity and a specificity that is higher those of other non-invasive technique for the detection of coronary artery disease. This is another example showing how well we can depict the coronaries, and thus not only the coronaries, of course, but all the cardiac structure and functionality with, again, a very high sensitivity and very high negative predictive value in these patients. So an extremely good technique to exclude the presence of coronary artery disease or to confirm and trying to quantify the burden of the coronary disease. So where we are now, of course, in these 10 years, the technology has changed a lot. We have far better scanner. Right now we are bringing cardiac CT to the clinical practice, and also we are making our technique more gentle, so using less radiation and using less contrast media. These are just few. I'm not going to talk about all of them, but these are just some of the changes. All these changes, like the automated tube voltage selection, iterative reconstruction, contrast media, and radiation tracking, all these changes have significantly decreased the radiation dose and the contrast amount we need for a cardiac CT. That's important because radiation dose can be dangerous for the patients, also for the doctors or physicians, sometimes, like in this case. And, well, And so another example, right now we are tracking the radiation dose in every single patient. That's what we are doing at Emory. That's one of the software we have. So we can track the radiation dose we are giving to our patients. We can do population analysis, what is our radiation dose for each patient, for each technique, for each hospital. And so we can have, let's say, a very accurate evaluation of where we are going, if we are doing well, if there is some outliers, why we have outliers, and thus try to always improve our amount. And that's an example of how the radiation dose have decreased. If we compare the CCTA with other technique like nuclear, you can see that right now with the most utilized acquisition technique, which is the prospective triggering, I'm going to show you a bit more about that, the radiation dose is about 3.5 millisievert. Far decreased compared with what we were using more commonly, that was the retrospective gating. And right now, with the latest scanner, we can do also the so-called single heartbeat acquisition, where we acquire the heart in just a single heartbeat in a single R interval, and thus we can go far below the 1 millisievert. So I'm going to show you dose that can, let's say, resemble the dose of a chest X-ray to acquire a cardiac CT. So definitely a great improvement or a great reduction in radiation dose. I was telling you about the most utilized technique right now, the prospective triggering. In the prospective triggering, we are acquiring just a phase of the cardiac cycle, usually the diastole or the systole. Usually that is based on the heart rate. And in that case, we do not have to acquire all the cardiac cycle, right, like we are doing, because with our scanner, we are sure that we can get good image quality, especially if the patient is having a regular heart rate and a slow heart rate, usually below 80 beats per minute. And in this case, the radiation dose is pretty slow. We can also do, as I told you, in patients with very low and stable heart rate, usually below 70 is better. We can do the single heartbeat acquisition in just a single heartbeat, and in this case, we have a radiation dose that is going to be extremely low, and the acquisition time is the scan time is 0.2 seconds. So usually this patient should be tied to the scanner when we are doing the acquisition. The results are very good in selected patients that are being treated. Usually as I'm going to show you, we give them beta blockers, and in this case we can acquire images with 35 milliliter of contrast. In the past we were using more like 80-100. But we can do this in selected patients, and again with just 0.4 millisievert. That is 10 times the radiation dose we are using, for example, for a chest X-ray. So that's how low we can go with the new technologies in cardiac CT acquisition. What do we need? It's of paramount importance to get a good image study, a regular heart rate, and also we prefer that it's going to be slow. And that's why we are giving usually before the study beta blockers, and also because to counteract the effect of nitroglycerin that we give to improve the dilation of the coronaries. In this case, the heart rate, we are also doing patients with our, for example, latest scanner here, the Force. We can do patients with 80, 90, also 100, of course, heart rate, but definitely in that case, not always we are sure that we're getting a good image quality. Of course, we do that if there is no alternative and if the patients need that. But it's preferable to be able to, or to have a patient with a low heart rate to be sure that we are getting the best image quality possible for the plaque characterization. And again, with this new technique, we can again go very low with the contrast dose that we can use. And you can think all those patients with a renal problem, renal failure, frail patients where we want to decrease as much as possible our contrast dose. So moving toward the clinical applications. First of all, I mean, the most utilized and also most, let's say, validated application for cardiac CT is the coronary artery calcium score, where we are doing a non-contrast acquisition, and we are then quantifying the amount of calcium in the coronaries. We know from the Framingham study and from other studies that this is a very good, it's an extremely good relationship with patients, let's say, risk profile, and we know there are really tons of evidence that is actually right now is the most useful of the current approach to improve the risk assessment among individuals with intermediate risk after formal risk assessment, and also is the best actually predictor for future events in the general population, in the elderly, in person with diabetes, and this is very good to stratify those patients, because of course, for example, a diabetic patient with a very high calcium score has a different risk from a diabetic patient with no calcium at all or very low calcium score, and that is independent from other risk factor. Also, it's proven that the knowledge that you have calcium score, you have calcium in your coronaries, is also having, let's say, a beneficial effect on the patients because it's proving the adherence to the therapy, and that's why there is a Class 2A recommendation for the assessment of cardiovascular risk in asymptomatic adults. So calcium score has been, in the past 30 years, has been widely studied, and we know that is a very effective method to evaluate the risk factor and the risk score of patients, of cardiac patients. For the coronary CT, we have actually several indication. We can use the coronary CT for the detection of coronary artery disease in symptomatic patients without known heart disease, and both in non-acute or acute presentation. Usually the best patients recommended is in the patients at intermediate risk for coronary artery disease. We are doing evaluation for after revascularization, so for patients with stent, patients with CABG, to see if there are patent, if there are stenosis, intimal hyperplasia. We are doing also planning, as I'm going to show you right now, for the application of cardiac CT for the preparative planning of mini-invasive technique like TAVR, or for example mini-invasive mitral surgery is growing a lot. We are doing a lot of these studies for that setting as well, and that's what I was telling you. Again, also the preparative evaluation for atrial fibrillation, and in this case I'm not even mentioning, because it's a bit more specialistic, all those applications for congenital heart disease, or in this case cardiac CT, especially the new scanner with very low dose, has been widely used, for example, for the structural evaluation. But definitely these are all some of the possible indications why we are using cardiac CT, coronary valve evaluation. What is the real clinical implementation? So right now, we know that in the US, following the guidelines for stable angina, is favoring the non-invasive functional testing for myocardial ischemia. So SPECT is the most utilized, in this case, technique for the evaluation of stable angina. And CTA is more, let's say, reserved to those patients without established coronary artery disease who have already undergone a functional testing. So we need, after a SPECT, for example, to confirm or to rule out if there is a real, let's say, ischemia, and so there is a real underlying coronary stenosis, or for patients that are unable to undergo to that one. However, we know that right now from all these several studies, we have new information that are telling us that cardiac CTA is actually the most accurate non-invasive method for the determination of obstructive or functional insignificant stenosis, and we're going to see also the improvement that have been recently, let's say, happen in that setting. And also in this case, after CCTA, we have the highest probability of requiring intervention in the cardiac catheterization laboratory, and that's important because we know that usually after nuclear stress test, only 44% who underwent to a cardiac catheterization had obstructive disease. So the majority of those patients have not real obstructive disease, and that's why those patients could be ruled out, for example, with cardiac CT, and could have prevented in some way the invasive route. Again, these are just some very few of the evidence supporting the application of the coronary CT. The famous, again, PROMISE trial, that was a prospective multicenter imaging study for the evaluation of chest pain, and we know that 72% of patients undergoing invasive coronary angiography after CTA, after cardiac coronary CT, had obstructive disease, compared with only 47% of functional test group patients. That was already demonstrated in previous study, but this was the first multi-center trial showing prospectively this one. And again, CCTA demonstrate a significant improvement in identifying patients with obstructive disease in comparison with other non-invasive functional testing. But also one of the most important things that I'm going to show you, also the most recent evidence that are coming in that regard, is that we have a significant prognostic value of CCTA in comparison with other testing strategies. In this case, there are evidence that we can reduce in the population that is tested with CCTA due to intervention and also to implementation of medical strategies, the fatal and non-fatal myocardial infarct, and also we are increasing the event-free survival compared with other standard care group in this case. That's how things are changing. These are the first guidelines in 2006, the NICE guidelines from UK that have changed and have recommended the application of CTA, then at least with a 64-slide CT, for as a diagnostic testing for people in whom the stable angina cannot be excluded by clinical assessment alone. And again, recently we know that some of the, like United Healthcare, allows the use of CCTA as a first-line testing for symptomatic, in this case, individual, removing the need for standard stress prior CCTA, and this was not available before 2018. So things, and of course, based on all this evidence that we have accumulated in the last decades, things are changing in the indication for the coronary assessment in cardiac CT. And again, the reason for these advantages is that with coronary CT we are having a direct visualization of the coronary atherosclerotic burden. We can see the CAD localization. We can see, for example, of course, there is a difference if the stenosis is involving diffusely the proximal LAD or it's just mild diffuse anomaly or coronary plaques in all three vessels. We can assess the stenosis severity, and again, we can look at the plaque composition and morphology. We can see if it's a calcified plaque, so more stable. We can see if there is a soft plaque. We can see if there are high-risk features that again are going to be positive remodeling, low attenuation of the core, and then the napping ring sign, the major high-risk feature for plaques in this case. And in this very nice editorial that was recently published, they also are very well explaining why there are advantages. Because if you look at these three different settings, where in all of the three cases we had a normal scintigraphy, these are three different patients. The scintigraphy is normal, is negative. But if you look at this one, we have a completely normal coronaries. There is no plaques at all. If you look at these patients, we have instead a diffuse non-obstructive three-vessel disease, so diffuse coronary artery calcification. And again, in these patients, we have non-obstructive disease, but one of these patients is one of these plaque, like this one, in the LAD, is a very high risk plaque with very concerning or worrisome features. So these patients, with a normal functional stress test, has a very different situation or underlying situation of the coronaries. And these patients have a very different risk factor and very different, in this case, prognosis as well. This is the latest of the article just been published a few months ago about the prognostic value of CTA, and is the Scott Hart trial. This is the second paper from the Scott Hart investigation that basically they followed for 5 years patients who underwent to a cardiac CTA for myocardial infarction. It was a multi-center open-label parallel group trial with randomly assigned more than 4,000 patients, and 2,073 were assigned to the CTA pathway, and the other half were assigned to the standard care alone. Results were pretty interesting because they showed that patients that were assigned for the CTA pathway had a reduction in the myocardial infarction and also non-fatal myocardial infarction. There has been a lot of debates about the reason, if there was, of course, bias or was a real also result. Actually, there are several studies showing the same, but the reason that are if you look at the journal, there is a lot of people debating of this. Could be that in this case, people with a person or patients with diffuse or with visualized coronary artery disease disease, obstructive or non-obstructive, usually are patients that are undergoing to more treatment or to more care. There are patients that are more likely to be under statin or under aspirin, are patients that are more likely to be adherent to therapy, and also are patients that are more, let's say, studied. So this can be one of the reasons why there is, for example, this difference in the group of patients in this result in patients undergoing CCTA. Not only, as I said, stable angina or elective patients. Right now, cardiac CT is very well, pretty much utilized also in patients in patients with chest pain, with acute chest pain, because with cardiac CT we can do several things. As you can see, it's going to change a lot. Usually our diagnosis and also the pathway that we can get from these patients. If you look, for example, a different group of patients with suspected STEMI or ACS, we can use CCTA in the early assessment pathway because it's telling us if those patients are going to have, if the chest pain is from cardiac origin or not, for example. And also the other advantage is that, again, also in the observational pathway, cardiac CT is telling us a lot of information. You should also consider other interesting thing when we compare cardiac CT with SPECT, with CMR, with echocardiography. Usually cardiac CT takes, the scanner time is going to be usually 10 minutes. And we just need a 10 seconds acquisition. And then, of course, the analysis and the reconstruction. But it's a pretty fast technique. So in this case, we can pretty quickly look at the coronaries, and not only, because then if the patient is a patient where is not a defined diagnosis, so we don't know if it could be, let's say, pulmonary embolism, aortic dissection, coronary disease, we can do, or where one of the protocol we do mostly is a triple rule-out protocol, where we do an entire acquisition of the chest, and we can rule out the three major, of course, disease, so again, dissection, coronary disease, and pulmonary embolism, but we are also looking at the rest of the chest. So a lot of times you find other reason for the cardiac, for the acute chest pain, in this case from every kind of possibility. And these are just some examples, alternative causes for acute chest pain that we can easily find, or severe calcified aortic valve. You can see mitral prolapse, like in this case, of flaking leaflet. A lot of times we can find also, infection, and not only. We can find coronary anomalies. We can very well depict, as I was telling you, it's very easily for these techniques to find coronary anomalies. In this case, is a malignant pattern of this right coronary artery arising from the left coronary sinus with an interarterial course, and this is another example where the circumflex is arising from the right coronary sinus and with a retro-aortic course, so a benign, in this case, pattern, we're not causing any in this case, any squeezing of the coronaries during the systole. We can see very peculiar cases like the Takotsubo. As you know, in this case, the coronaries are perfectly clean and neat, but we have a complete lack of contraction of all the mid-apical wall. So in this case was the patients recover after a few weeks the normal function, so was a stunned myocardium in a Takotsubo case. And we can also see very subtle, we can also make other subtle diagnoses that usually are not easily to visualize. This is a 43-year-old patient presenting to the ED with chest pain radiating to the left arm. Patient was 14 days after a post-uncomplicated vaginal delivery, and the initial diagnosis was postpartum cardiomyopathy based on the dilation. Troponins were very low. In this case, it's a very interesting findings and very subtle, because if you look, you can maybe appreciate all these very subtle abnormalities along the proximal LAD that also is confirmed here. So you can see a very regular, let's say, wall profile of the LAD. If you look better, you can see all this hypodense tissue there. This was a confirmed also by angiography LAD dissection in these patients. So in this case, we can also, as you can see, we can find far more cardiac abnormalities than the simple coronary artery disease. We are looking at the heart at the entire heart. So we are looking at the function and the contraction, and we are looking at the coronary together. together with the valve and all the other structure. Again, we have several papers have shown that also the application of a triple rollout CCTA into the triage strategy improve the efficiency of clinical decision making. It does not decrease the overall cost of care, but it's going to usually decrease also the amount of time that the patient spend in the ED before a diagnosis. Well, how do we report the coronary CT? This is, I guess, is very important also to make it clear how we do that and how we can integrate. We are using the CAD RADS. The CAD RADS has been recently, just 2 years ago, approved and validated by the societies. Usually we are using a CAD RADS from 0 to 5, where a CAD RADS 0, there are no plaques, in this case at all. A CAD RADS 1, there is 1 to 24% stenosis of the vessel. A CAD RADS 2 from 25 to 49. 3 from 50 to 69, and above 4 is from, of course, severe stenosis like 70, 99 with differential, A, B, according if it's involving the left main or not. And CAD RADS 5 is a total occlusion. So, of course, it's not always possible to be 100% accurate, meaning that it's difficult to be sometimes if it's 49 or 51%, but we can definitely doing a pretty good job, as has been demonstrated, in assigning the patients to the right CAD RADS with all the clinical implication that this can have in these patients. So right now, what I show you is that cardiac CT, let's say, has left the initial validation pattern or the initial validation stage. Right now is a pretty accurate technique for the evaluation of coronary disease and cardiac disease in general, based on the indication. But we can do far more right now. There are more things that are coming, and this is a nice patients with multiple CABG, for example, showing you, so we can actually evaluate all the entire chest. Right now we are going to, let's say, the cardiac CT functional imaging, where we are trying to evaluate how we can assess and what is our accuracy in the functional CT imaging compared with other functional technique. As already said, CCTA has been in several pathways used as a gatekeeper for functional testing or invasive diagnosis, and we are doing pretty well actually, but this is not enough, because we know from several studies, the most famous, the FAME study and the COURAGE trial, that we need to guide our revascularization on the functional assessment of the lesions. So we need to know if that lesion is really causing ischemia, is a really flow-limiting stenosis. Otherwise, there is no benefit in treating that lesions. So that is a paramount importance to have techniques that can tell us both. You can visualize the plaque and can also tell us if it's really a significant plaque. Right now, we can do that with two different ways. We can do a myocardial CT perfusion under stress and rest, like we are doing for nuclear imaging, or we can do the CT fractional flow reserve, which is a non-invasive assessment of the fractional flow reserve of the vessel, like has been done in invasive angiography. Starting with the perfusion approach, we have different way. We can do a static approach, where we just acquire the passage of the contrast media in single energy or in dual energy, or we can do a dynamic approach, where we are acquiring all the, let's say, the arrival of the contrast and the distribution in the myocardium, and we can do quantitative imaging. Just few notion, to show you what we are able to do. This is, for example, is a 60-year-old male with stenting of the LAD, and we can see, for example, that there are all these chronic infarct, in this case on the anterolateral, but also on the inferolateral and anteroseptal wall, for example. The single energy is used, but actually has been replaced by the dual energy acquisition, because with our scanner we can move to the spectral imaging. To give you an idea what is spectral imaging, with a CT right now we are distinguishing the objects based on the density, if it's more dense or less dense, and we try to differentiate calcium or other material. Doing a spectral imaging, we are acquiring a different energy, the same structure, and in that case we can create different spectral profile. And that allows us to separate materials. So I know that then what is going to be iodine, I know what is going to be, for example, blood or fat. So we are moving to a material-specific imaging. That is very useful for the perfusion, because what I can do is that I can create perfusional map, like in this case, this is dual energy acquisition, where they can very well so depict where we have iodine uptake or iodine, in this case, flow, and where we have iodine, let's say, lack of iodine due to secondary to myocardial infarct. And as you can see, we know that right now we have a very good matching with the perfusion techniques, and you can very easily also appreciate that there is, even if it's not a metabolic imaging, still it's in this case a functional imaging, and it's telling also us we have a very high resolution, spatial resolution, in this case, that is very helpful for the detection of small perfusion abnormalities. These are other cases comparing, for example, inducible perfusion defect, in this case in the LAD territory, very well matching during stress with regadenoson, the SPECT anomalies. And again, since we have a higher spatial resolution with CT, you can see that we can very well appreciate subtle abnormalities that are not easily detected with, for example, with SPECT. In this case, there was also an ischemia of the papillary muscles that was very well matched in the MR, in this case, other than the lateral wall, but was not visualized. We don't visualize the papillary muscle with the SPECT. The second technique is the dynamic perfusion. We inject the contrast and we acquire all over the cardiac cycle, in usually 60 seconds, the arrival and then the pass of the iodine. And in this case, the advantage is that we can do quantitative analysis. So we can evaluate the myocardial blood flow, we can evaluate the myocardial blood volume, and in this case we can have then threshold. This is absolute threshold telling us if there is a reduction or not of the perfusion. We know from studies that, for example, we use for the segmental ischemia 578 milliliter as a threshold for ischemia. For global ischemia, we found that the threshold, like the whole cardiac threshold, was higher. So we can do, let's say, myocardial quantitative imaging with these techniques. And also several studies, just one of the initial that we did, demonstrated that the presence of myocardial perfusion abnormalities is a very important prognostic factor. I mean, and also matching and repeating what has already been done with since in the last decades with nuclear medicine. So of course the distribution, the extent of these myocardial abnormalities is going to have a direct impact on the patient's outcome, so a very significant prognostic value of the myocardial perfusion in this case. Just to tell you also what is going to be, let's say, the advantage of this one, and this is a very complex patient with hypertension, with CAD, cabbage, stent on the RCLAD, coming for the new onset of chest pain. Doing the dynamic perfusion CT, we can tell that two venous cabbage are patent. The lima graft is occluded, is atretic, and also we can see that there are chronic myocardial infarct in the anteroseptal wall and in the infralateral wall, transmural and subendocardial. What we can do with the perfusion imaging is that we can see that there is this area of transmural perfusion defect in the anterior wall, so likely this is going to be a peri-infarct myocardial ischemia in the same territory of this atretic lima. And we can get all this information with a single study. With other study, we don't know, for example, with the SPECT and the MR, the status of the underlying coronaries and cabbage, so they need to do a CAT angiography to visualize which one is the cabbage down. And also we don't see, also of course with MR in any way we can get a lot of information, and you can see that the ischemia, both with SPECT and MR, was matching, in this case, the ischemia we were seeing at the CTA. So with one technique, we got information about the coronaries, the cabbage, and the status, the underlying status of the myocardium, thus finding where is the problem. Moving to the second way to do functional assessment, fractional flow reserve. In the past year, as you know, this has become a clinical applied technique. What we are doing is that we are using the same CT images we acquired to analyze the fractional flow reserve. And they do this without the need of additional acquisition or any pharmacological stress. We just send our data set. In this case, there is only one company in the world doing this right now that is a HeartFlow. And in this case, you send them the data set, and the day after, usually it takes 4 or 5 hours of analysis in this supercomputer, they calculate the fractional flow reserve, which is very well matching the invasive fractional flow reserve, so telling us that it's going to be a significant stenosis or not. There is also, this is the way we are doing now, is the computational fluid dynamic modeling requiring big computer and a lot of processing power. Right now we are doing that also with artificial intelligence, and we can do that with machine learning algorithm in the in-house algorithm. We have done that, and it usually just take from 20 to 30 minutes for the analysis, so far lower time. This is the only clinical available solution, HeartFlow. Has been validated on several multi-center trials, and in this case we know these are the 3 major trials: the Discover Flow, the De Facto, and the NXT. And the result is that the application of FFR is significantly improving the weak spot of CCTA that were the specificity and the positive predictive value. So in this case, they were able to determine which one is going to be a significant stenosis, and in order in the platform trial, another important trial in 2015, this brought to the 61% cancellation of invasive coronary angiography, because in that case, the significantly decreasing the amount of invasive technique. There are also other things that are under validation, under studying, like, for example, the planning for virtual coronary stenting, so to see how change the flow in the coronary after we put the stent in that position or in that branching area. And again, we can also do for research, because are not clinically proved, CT-FFR using different machine learning algorithms. This one, the first one that was available, we validated that at the MUSC in the past years, and it's very interesting because you use the power of machine learning for different neural networks to train the system on synthetic data set. What does it mean? It means that they created 12,000 synthetic data set with every possible branching and anomalies of the coronaries to predict the flow. And in this case, we know from the result of this, the machine consortium, which was a study between 6 large institutions using this technique, in comparison with the standard fluid dynamic application, the results were the same. So there was no difference in the results between the application of the CT-FFR with machine learning or with computational fluidodynamics. And again, you can also become more fancy, doing in this case, combining the dynamic perfusion, like in this case, with the CT-FFR to have a complete evaluation, in this case, of the coronary stent, the coronary plaque flow significance, flow limiting significance, and myocardial, in this case, perfusion. The clinical implementation actually right now is a Category 3 CPT code starting January 1st, 2018, and right now is reimbursed. So in this case, it's possible to do FFR. What we have to do is just to send the data set to the HeartFlow house that is in California, and they send the day after the result of the FFR analysis. Few words on what is coming. Artificial intelligence, as you know, a sandbox term that right now is being widely used, inappropriately used in every possible way, but there is a lot of potential also for cardiac imaging. What we are using, the most utilized application are based on the deep neural networks, so networks that are working or are very good in pattern recognition. In this case, the different layers are able to detect different things like shapes, edge of an image, other things, and based on that they can find a pattern that can help us in doing a diagnosis or a prognosis in our clinical application, like recognizing the calcium score or doing a prognosis of the outcome of the patients based on all the information. These kind of networks become better and better with the amount of data. More data we train them, bigger model, better is the accuracy. And right now there are several applications, like for example going from just the functional analysis, or speeding up and improving our workflow, doing, for example, automatically all those analysis like the cardiac function that we are right now doing in a time consuming. But more is coming. We have a lot of these computer vision algorithms that are being utilized to detect anomaly, for triage, for co-registration, till to the computer-aided prediction that we can call like the holy grail of this kind of prediction, because it would be, help us in making better prediction for these patients. These are some research that we did. Is an algorithm we trained to do to detect the calcified and non-calcified plaques automatically, so to give us an automatic quantification of the coronary burden without any manual human involvement. And then again, to give you what is the potential of these, the future potential, the possible potential of these techniques. This is a very nice study on mortality prediction, combining clinical information and CCTA. In this big study group, they combine different prognostic methods for the patients, and the machine learning approach was the best one, surpassing all other score for the mortality prediction. But the most interesting part is this one. If you see, this is a model of all the risk factor based according to the prevalence or to importance of each risk factors. If we look more closely to the most common 15 risk factor, of course the first one is the age. But then, if you see all the rest of the risk factor among the clinical risk factor and the imaging risk factor, you can see that the vast majority of the risk factor with a higher importance were all from the imaging, were all from the CCTA. Because in this case, the possibility to directly detect the presence of calcified, non-calcified plaques and the extension, the localization in the coronaries is has a very important prognostic implication. That it also in this case, in this large study, was giving a higher, let's say, prognostic implication compared, for example, with smoking history on other risk factor. And that's very interesting because all of these can bring in our clinical practice the so-called radiomics, or the extraction of all of those numerous quantitative features from an image that right now we are just starting to scratch the surface, but we could really do, in this case, an analysis of every single imaging, let's say, anomalies, and weight that anomalies for the clinical implication that's mean. And there's going to be a big change in the imaging. Of course, future challenges of these artificial intelligence. First of all, ethical challenges. We know that when we train this algorithm, if we do not do that in the right way, we are training with bias. So these algorithms are not applied to the general population, and that's a very important, very critical part right now. And also, we need, of course, a lot of data. We need good quality data, not so easy to acquire, because we need to create the ground truth analyzing this data, and we do not have right now all the manpower to analyze millions and millions of data. If you imagine about that, we need post-market surveillance, and finally the cybersecurity importance. So in conclusion, based on this, I guess we can say that right now, with the latest technology, CCTA is an accurate technique for the coronary and cardiac evaluation in several clinical settings. Of course, the most appropriate clinical setting is the indication are based on the type of analysis you want to do. The anatomical and functional CT imaging in the setting of myocardial perfusion or fractional flow reserve actually right now give us the possibility to assess in a single examination the functional significance of a lesion, also other than all the morphological implication and localization of that lesion. And finally, machine learning is coming more and more, especially in the imaging realm, and likely will enter, hopefully will enter our practice pretty soon, and thus improving our diagnostic and prognostic abilities. And with this, that's all. Thank you very much for the attention.
I guess one question I would start, and then we'll open it up to others, is the thing that we've thought through the years is looking at CTA is that you couldn't pick out the vulnerable plaque. Now, it looked like you were making inroads now into picking out the vulnerable plaque by some of the things you were showing. But if you looked at the criteria that you gave us, what's the specificity of saying, I know that's a plaque that has a potential rupture?
Yeah, I mean, right now we have the three most that I showed you. The three most let's say utilized risk aspect are the napkin ring sign, which is likely probably the strongest let's say predictor of a vulnerable plaque. The bad thing is that it's not that easy to spot that sign, because sometimes if the plaque is small, I showed you a very nice example of a napkin ring sign, but a lot of times you have a soft plaque and it's not that easy to pick up all these features like that sign or the hypodensity that usually we are using, like a cutoff that is likely 70 ounce per unit. So we can find that it's not that easy to spot these indicators when we are analyzing the plaques. Definitely an important thing is in any case to tell if the plaque is calcified or non-calcified, because in any case a soft plaque in general comes with a higher risk, of course, than a calcified plaque. So in that case, seeing what is just the plaque composition can give us an indication. If we are able to look at those indicators like the positive remodeling and the napkin sign, that definitely can improve our accuracy. I don't remember actually right now the exact numbers, but in all the studies where this sign has been evaluated, the accuracy was good. But again, it's very important.
Like specific, but not very sensitive.
Exactly. It's very specific, but not very sensitive. And again, it depends also a lot from the image quality, because to spot that signs, you should have a very good image quality, and you should do a very good study. And it's not always the case in every setting.
Other questions?
Thank you very much. That was a pretty remarkable presentation. Thank you again. I wasn't quite sure about the low-dose CT, minimal dose CT, and FFR. Is it possible to do FFR with the low-dose CT?
It is. It
Okay.
is, again, FFR. Usually there is, when you send the data set to them for the analysis,
Yes.
there is a rejection rate about 20%, 15-20% of cases. It depends from the study. Sometimes it was 10. Based on more than on the radiation is more based on the presence of motion artifacts. So if the heart rate, there is an ectopic heartbeat, or the heart rate is too fast, and we have some motion artifacts, sometimes the analysis is not able to correct that, and they cannot do the analysis. But with the low radiation, usually there are no problems in doing that kind of analysis. It's even better because if you go down with the radiation, you are going down with a KV, you are increasing your contrast attenuation. So you are seeing more contrast attenuation in the vessel.
And California is the only place that's actually doing the analysis?
No, it's all over the world. We just that's the only company doing that, but right now also at Emory we are discussing for research. There is some research project involving them, and you can just start the collaboration and send them the data, and they send you back the result usually the day after. They are doing that from Europe, from every base, but of course the processing is done in the U.S. in California mainly.
Well, thank you. I can preface this question by saying I'm neither a cardiologist nor a radiologist, so I'm trying to figure out which one of you is going to win in the end here. But if I understand correctly, and Doug, you may want to weigh in this as well, it sounds like we're moving to a point where the cardiologists will do fewer diagnostic catheter procedures and a lower percentage of their use of a catheter will be for intervention. If you understand the question, I mean, it sounds like you guys are getting to the point where you're going to be able to define the anatomy, but also the impact physiologically in terms of on blood flow of a lesion that typically was picked up more by catheterization. Would that be fair to say, Doug, or for you?
Fair to say, and I'd say it's not only the future; it's already started. I mean, we do less cath.
It is, but I guess also it's going to be, maybe preferable for the cardiologist doing more interventional procedure than diagnostic procedure. I guess.
We have an off-site question from Grady. I think I'm reading the question correctly. Are you seeing providers use more CTAs over nuclear stress testing for risk stratification for moderate to severe pretest probability for CAD?
The question is, are they using more? Well, the answer is no, because first of all, there are logistic reasons. I mean, right now we have, SPECT is very validated, and PET, especially PET, is very validated technique. And in the majority of cases, or in the US or everywhere, we have a very large, number of SPECT and PET machine. Instead, we do not have a lot of cardiac CT dedicated CT, and also when we have, like in our case, we are doing also other studies in those CT. Second, also there is, also an education time, in the meaning that these techniques is pretty new. And so we are gathering since in the last decades all this evidence, but still, there is, a penetration issue and factor that we should bring also this knowledge that you can alternatively do a cardiac CT if you don't want, or based on what the guidelines recommend for that patients. And a lot of providers are not aware that we are at this point of with cardiac CT that we can reach these results.
I guess before we close the cath lab and the stress lab, I just wanted to offer a little, obviously a very powerful technique evolving, but I will push back on one of your statements about that you thought this was the best technique for screening for coronary disease. And yes, it has tremendous accuracy, but for example, most of the patients we see, quite frankly, in an outpatient setting have a normal EKG and can run on a treadmill, and the negative predictive value of a negative treadmill is very strong. And the practical aspect is many insurers would not approve a cardiac CT as an initial screening for that. And they're appropriate in doing that. So we're not closing I don't think we're closing the stress labs yet.
Absolutely.
And then the other thing I would say is that, I know at one point you said a 50% specificity, I guess it was, or positive predictive value for a nuclear stress. I mean, that's probably a little over what's really seen if with appropriate interpretation, because we interpret these not in a binary fashion, as you know. We would see, for example, if you see lateral septal redistribution in someone with hypertension, that would be read as a positive, but we might know that that's probably a false positive, or a 7% defect on the inferior wall. We would probably not pursue that patient as likely diaphragmatic artifact. So, I don't think we're ready to close everything. And just for the residents, I just think it's important to remember, some of the standard stress tests in the right settings are probably economically superior and much more convenient for the patient as you can do it in the office setting.
I totally agree. Also, to give you a better perspective, I spent my last 2 fellowships in nuclear medicine doing mainly cardiac. And I agree with you in the meaning that definitely is a powerful test, has been here, is far more standardized than CTA right now, of course, in several clinical settings. And however, I guess that cardiac CT can be a powerful tool that can be used together with stress test. And definitely with the speed, with also usually is compared with nuclear is a low-cost technique. Is less expensive. If for the emergency setting, for the acute chest pain, is really, really useful. So I'm not saying that should replace nuclear medicine or stress tests. I guess we should utilize that cardiac CT more, because right now is, to my opinion, not only to my opinion, is underutilized.
I was just going to add that your third case, just for the residents, it was a young woman with EKG changes and a troponin of 6. That could have been coronary spasm, and that's the one diagnosis, vasospastic angina, that the CTA wouldn't be able to pick up.
Correct. There are cases where we're not able to see that.
Any other questions? All right, we thank you very much.
Thank you very much. My pleasure. Thank you again, Dr.